Dr. Alizada's voice. She's mute, but just check it.
Sure.
Yes.
Yeah. So I'm just going to mute everybody. That's not.
Yes, everybody's ready.
Perfect. I'm just going to mute everybody, including myself.
Yes.
Mrs. Shafa, before that, can I say something?
Of course, go ahead.
Hasnan is there. Hasnan is there, Shifa. Hasnan is there.
Disconnected, and it will reconnect automatically in a few seconds. So I might rejoin in a few seconds. So that would not be a problem. Okay.
Perfect. Thank you.
All right, let's start in Bismillahir Rahmanir Rahim. This is Dr. Severity welcoming you all on behalf of IMI, Imami Medicine International, and Sadiq International University, the virtual wing, which is conducting the series of webinars and workshops. Today is a very special workshop. It's the first time in the history of IMI SIVU that we have a couple of workshops dedicated to our nursing colleagues. For some odd reason, we tend to concentrate mostly on the role of physicians in healthcare, whereas we must remember that nursing colleagues are equally important. In fact, in my view, they're more important than physicians, because life is incompatible if there is no nursing care, especially in this very difficult time of pandemic of COVID-19. We've seen it like in the NHS in the UK, that nurses have done exceedingly well, far more service to mankind than physicians have. And we greatly appreciate their services. In fact, for about 3 months, every Thursday evening, there used to be a clapping to praise the nursing staff as well as the other healthcare staff in the entire nation. In the UK, only a couple of weeks ago they stopped. So compliments to our nursing colleagues, and welcome you all. It's a wonderful day for all of us that we'll be hearing the experts in the field of nursing care, from prevention to caring. This is workshop 1. And may I request Hasnan to take over from here. He's the moderator for this session. Shifa is running the show from her office in Toronto. So IMI is providing this service throughout the world. We're expecting about 58 participants to a very special dedicated workshop only for the nursing care. Of course, all this material will be uploaded on IMI SIU webpage and will be available to other participants. Hasnan, may I ask you to kindly take over and introduce the speakers and the facilitators. Thank you.
Sure. Thank you, Prof. Shabi. Can you hear me now? Is it clear?
Yes.
Okay. First of all, I would like to thank all presenters and all the audience to officially welcome to this workshop. And I should actually give a personal thank you to frontliners. You know, you are the frontliner. You people are doing a great job in fighting the COVID and Corona. So I would like to introduce the first speaker will be Dr. Tahmina. Okay, and once they will come in, I would request them to, I think they themselves could take 1 to 2 minutes to introduce themselves. Then we will have Dr. Alice Khachiyan, okay, and then we will have Dr. Parisa, Dr. Mariam, Dr. Mahasati, and Dr. Sadeh. So all these speakers will be sharing their experiences for 20 minutes each, and then we will have a question answer session later on, and then the managers will be sharing their experiences also. So now I pass on to Dr. Tahmina, or Dr. Elias, if you would like to start first. You can unmute yourself. Dr. Elias, you need to unmute.
Hi, everybody. Can you hear me?
Yes.
Loud and
first of all, hello to everyone from different parts of the world. I'm really honored, and it's a really great honor for me to be a part of this special program. We, as the nurses of the Iran University of Medical Sciences, believe that working on prevention is more important than, curing. If you can work on prevention, it will have a better outcome than curing patients. So one of the major objectives of this workshop is this one. The topic of this workshop is COVID-19 from prevention to caring. And the audiences are nurses and nursing students. The workshop duration will be 4 hours, and the coordinator of the workshop is me. The workshop is designed for nurses or nursing students who has specific work in the hospitals or community and are involved in education of the population on COVID-19. In the end of the workshop, we expect the audiences to be able to describe the novel coronavirus 19, to explain COVID-19 signs and symptoms, to explain how to prevent the spread of the virus and how to treat it. Also define techniques for reducing transmission of COVID-19, identify ways to increase community knowledge on the best hygienic practices to prevent COVID-19, practice to respond to miscommunications or stigmatizing comments or behaviors in regard to COVID-19 virus on the basis of the ethical approaches, and promote nurse self-care, emotional and mental well-being. I hope the workshop will have the best outcomes that we expected. And the first presenter is Dr. Mahasti Alizadeh from the University of Tabriz. I want to invite her to start her presentation about the description, sign and symptoms, how to prevent the spread of the virus, coronavirus, COVID-19. Thank you. Dr. Alizadeh.
Yes, thank you. Hi, everybody. And I don't know if I will show the slides from my screen, or you have the slide. Maybe I should share it. I don't know.
Dr. Mashal, I think if you have slides, you can share your screen, and it's better to control yourself. Will you be able to share your screen or slides? If not, then I'll ask the Shifa sisters to share the screen.
Yes, I think.
Yeah.
Do you have my slide now?
Yes. Could you put it in a full screen or slide mode, slideshow mode? Yes, perfect.
Okay. Thank you very much. First of all, I would like to thank you all for this workshop. And also, it's an honor for me to be here with my nursing colleagues and other colleagues from the Sadiq University. My name is Mahasti Alizadeh. I am the professor of community and preventive medicine in Tabriz University of Medical School. As you know, Tabriz is located in northwest of Iran, and here you can see one of the landscapes of Tabriz, I think one of the very beautiful cities in Iran. What I'm going to talk about is about the description and signs and symptoms of COVID-19, and also the prevention of COVID-19, and a little bit on the treatment of this disease. Here is an overview about the virus. SARS-CoV-2 is a beta coronavirus that First of all, it was known in Wuhan province in China, and I don't want to go through the very, special virology concepts, just to introduce the virus and the family. The COVID-19 is the name of disease, and coronavirus is the name of the agent, the virus. COVID-19 is stands for coronavirus disease 2019, and it's a term by WHO for this disease. COVID-19 is predominantly a respiratory disease, and with spectrum of severity from mild to very, very, very critical disease. This is a short history of disease in the world. First, it's identified in November 2019, and then WHO declared the emergency, global emergency, at January 30 in 2020, and the pandemic, global pandemic, was declared at March 11, 2020. What about the transmission of disease? Predominantly, it is transferred person to person by respiratory droplets and by contacts, exactly like other viruses in its family, MERS and SARS coronaviruses. But these droplets that are a little large, more than 5 micrometer, they remain very shortly in the air, about less than 17 or 15 minutes, and it cannot travel a long distance. It's travel short distance, less than 1 meter. That's why we emphasize on physical distancing, because of the nature of the virus. In some occasions, the virus can transmit more than 1 meter. When someone is sneezing, or when we have central air conditioning or something like that. This virus can transmit by contacts. For example, when respiratory droplets remain on the surfaces and a person touch the surface and touch his or her eye, nose, or mouth, this is another way of transmission. And some studies shows the aerosol transmission, but not in our usual livings. In some special places, for example, in hospitals, where droplet generating procedures are done, then there may be some aerosol transmission. In most of the epidemiological studies, it's shown that the spread is limited to family members. Most of the spreads are limited to family members, healthcare professionals, and other close contacts. And close contact is less than 1.8 meter. And it's good to know about the duration of the virus that is going to be contaminated on the surfaces. For example, plastic up to 2 to 3 days, stainless steel 2 to 3 days, 1 day for cardboard, and 4 hours for copper. There are some other routes of transmission, for example, fecal oral transmission, and also vertical transmission from mother to child. We have there are some reports about pre-symptomatic transmission from people who are infected, but they don't have any symptom, but they shed the virus. About incubation period is the time from entering the virus to the body till the clinical signs of the disease, and median incubation period is 4 to 5 days. And in different studies, it's different from 7 to 40 days. 14 days. As I mentioned before, we have we have a spectrum of disease from asymptomatic viral shedding. In some reports, they report about 50% of patients, but 80% of patients are mild to moderate, with a very mild symptoms, respiratory symptoms, to moderate respiratory symptoms, and then 20% of patients have dyspnea, and we have to admit them in the hospital. So the spectrum is asymptomatic and mild to moderate 80%, severe 14%, and critical that they have multi-organ failure, they are 5%. This diagram shows the course of the disease. At first, in stage 1, that we say early infection. In early infection, the most response is viral response, and this phase is viral response phase. In this phase, we have just some mild symptoms like a fever about 37.5 to 38 centigrade, and dry cough, sometimes diarrhea and headache. And in lab tests, we may have some lymphopenia, maybe increased PT time, D-dimer, and LDH. But in stage 2, that is pulmonary phase, we have the respiratory symptoms such as shortness of breath, hypoxia, and in this phase we can detect some chest imaging abnormalities. And then from here, the host inflammatory responses begins, and it goes worse and worse. And in this phase, after host inflammatory response, we can have ARDS and other elevated inflammatory markers. These are the clinical presentation. The most common symptoms are fever, cough, and breath dyspnea, maybe dyspnea, and also respiratory symptoms begins around day 6, not the first days. And another symptom is anosmia, some problem with olfactory and maybe some taste receivers, and some one third of patients excuse me, have maybe show this symptom. These are some rare symptoms: rhinorrhea, sore throat, myalgia, GI symptoms like diarrhea, and other some neurologic symptoms like meningitis, Guillain-Barré syndrome, and so on. We have some definitions for the case. We have 3 definitions: confirmed case, probable case, and suspect case. Confirmed case is the case that is proven by the viral culture or positive PCR, or maybe some identifying the virus by electron microscopy. Probable case is a person who has not been tested, but she or he has a fever more than 38 degree, or acute respiratory infection, the symptoms such as cough, shortness of breath, or sore throat, and we have "and" here, a household contact with confirmed or probable case. And the suspect case has some clinical criteria such as fever more than 38 degree, or history of fever, or acute respiratory infection. And here, the epidemiological history is very important. If the patient has the history of in 14 days, the history of close contact with a confirmed case or international travel or a healthcare worker, these are the criteria of suspect case. What are the diagnostic tests? The most known case is PCR, real-time PCR. It's highly specific, so the false positive is rare. When a test is specific, the false positive rate is low, but the sensitivity varies with specimen origin and depends on different contexts. So the sensitivity is low. Then the false negative is high. If someone is negative in PCR, maybe it's false negative. But if it is positive, you can say near 100% that it is positive. You can have the specimen from the sputum, nasal swab, and biopsy and pharyngeal swab, and these are these person 72% or 46% are the positive rate of each of these sources. But a single negative test does not exclude infection. Don't forget this. We have a serologic test. Serology test is not so sensitive or specific, but it shows the evidence of recent infection, the evidence of previous infection. And if someone is IgG positive, you can say that in previous month he or she had the disease, maybe without any symptom. Other lab tests, for example, CBC, complete blood count, that we can see lymphocytopenia, maybe thrombocytopenia below 100, but it's not so common. We have some coagulation studies, for example, maybe slightly prolonged PT or PTT. We don't have any change in electrolytes, but maybe in some patients blood glucose is increased. Liver function tests, ALT, AST, or bilirubin may be elevated in some stages, and LDH also. And ESR will be increased, and CRP shows it's a marker of severity when it goes high. Other markers such as albumin or ferritin will be increased in some patients. About the prognosis, when we discuss about the prognosis, we emphasize on the length of the stay in the hospital and the mortality. Median hospital length of stay in one study in China was about 12 days. In severe cases, and 14.5 days in those admitted in the ICU. And mortality is different in different countries. Case fatality rate was about 0.25 to 3%. And in some countries, we have more mortality. For example, the mortality of this disease depends on some demographic issues, like age. It depends on the screening programs of that country and the policies of that country on prevention of disease. And also the definition of disease may be different in different countries. What are the risk factors for severity of disease and also for mortality or fatality? Age, it's important to know that any age can develop a severe disease or even a severe respiratory failure. But most of the mortalities are in more than 60 years and 80 years old in old persons. But some children also may have severe disease also. About gender, maybe in most of the studies, female has affected less severely than male, but this effect may increase with age. About the, excuse me. Sorry.
Yes, you can continue, doctor.
About the comorbidity, most of the coexisting disease may worsen the course of disease. For example, cardiovascular, the most common diabetes, coronary respiratory disease, hypertension, cancer, and these are the most common comorbidities that worsen the course. There are some therapies that are under study. The one that has a possible benefit now is remdesivir. It's an RNA polymerase inhibitor, and it is under trial, and also it's not, but it is maybe in some trials it shows less mortality than other medications. Another drug that its effect is uncertain is Calitra. Calitra is a combination of lopinavir and ritonavir. It's antiretroviral agent that, as you know, we use it in HIV positive patients. It shows some reduction in mortality, but not as much as the remdesivir. And some other medication that we have used it from the first days of epidemic, but in different studies it showed that it's not so, it has no enough benefit with likelihood of benefit of potential for harm. It's chloroquine. It's hydroxychloroquine, and maybe corticosteroids, and maybe immunotherapy. The RCTs shows that they are not so beneficial. What about disease prevention? I think Dr. Alice will explain more about that. I just go. I just explain some general issues of prevention. What is important in prevention is to know about the way of transmission of disease, and so use something that prevent these transmission. We should decrease the close contact with our physical distancing, avoid touching one face, and also using masks that I think Dr. Alice will explain more about that. About the health workers, what does the system do for them? They should have continuous education about the prevention of disease, and also regular cleaning the environment, the equipment they use, and also they should have some ventilation, appropriate ventilation where they work, and they should also obey the rules of social and physical distancing everywhere they work, in lunch breaks, in their pavilions, and everywhere. And some high risk workers, health workers, should have off, especially in very severe days of the epidemic. they should have some shift breaks, and also they should have some we should have some limited number of healthcare workers. We can use telemedicine or remote technologies, and also preparing some PPEs for them. Health workers most of the time use face mask and also face shields. This picture shows the positive and negative issues of each of these. For example, you can in mask you can create a complete seal, but in shield you cannot do that. And also about healthcare workers, as I said before, they should wear a medical mask, and Dr. Alice will explain more about this issue. About general public, again, we have some, I think my time is over, yes? Okay. I think this is maybe the last slide. The most important thing is to prevent the transmission and to cut the transmission cycle with mask and also with some distancing, physical distancing. And most of the people, not health workers, can use fabric clothes that it can make from cotton or other material, and they can use in 2 or 3 layers with some other material adding to that. I mean, combination of material. So these days we are in bad days in our life and about our work, our education, everything. But it won't be like this forever. You know that it won't be like this forever. We can have the success on COVID-19, and we hope a day that things get back to how it used to be like before. Thank you very much.
Yes, thank you, Dr. Mashati. It was very nice, comprehensive, guideline you shared and your experiences. Dr. Elias, you are around. Can you actually invite for next speaker?
Is it shared?
Is Dr. Elias?
Yes.
Yeah.
Hi, everybody. Can you hear me?
Yes, it's clear, loud and clear.
Yeah, my slides?
Slides, not yet, yeah.
Mm-hmm.
Kindly spend 1 to 2 minutes to introduce yourself. I think you are the best to introduce yourself on your achievements and all that from which university. And I would like all attendees to use chat to ask questions and interact. So back to Dr. Elias. Yes, we could actually start now. Thanks.
Okay, if you let me, I'll start with introducing myself. I'm Alice Khachian, a faculty member and associate professor of Iran University of Medical Sciences, Nursing and Midwifery School, also head of Department of Medical Surgical Nursing. It's a great honor to have a presentation in this workshop, which is held for the first time in nursing faculties. And I'm very happy to have my colleagues from the different parts of the world, which is a great honor for us to have a good workshop. The topic that I'm going to present is techniques for reducing transmission. Of course, in the previous presentation, some parts were, mentioned, but As a summary of the previous presentation, coronavirus is an infectious disease, and it's defined as an illness caused by novel coronavirus, causes severe acute respiratory syndrome, and it was first identified in Wuhan, China, with a respiratory sign and symptoms. For the first time, it was reported to the WHO on December 31, 2019, and on January 13, 2020, the WHO declared it as a global health emergency, as Dr. Alizadeh mentioned. Because it's a epidemic disease, anyone may suffer mild to severe symptoms from this coronavirus, and the people with high risk will develop more serious complications. Who are in the high risk category? The older adults and people who have severe underlying medical conditions like heart or lung disease or diabetes mellitus. They will have severe signs and symptoms. So the sign and symptom of disease can be from the mild to severe condition, and illness appears from the second day of exposure till 14th day after exposure. The signs and symptoms could be cough, shortness of breath, or difficulty breathing, fever, chills, muscle pain, sore throat, and newly loss of taste or smell. All were mentioned by Dr. Alizadeh. But what to do about this pandemic condition? The first what to do is wash your hands frequently with soap and water for at least 20 seconds, especially after being in a public place or after blowing nose, coughing, or sneezing. We should wash our hands for 20 seconds. If we cannot, we didn't have any access to the, soap or any water or soap, we can use hand sanitizers. But the hand sanitizers could have 60% alcohol at least. When we are using sanitizers, we should cover all surfaces of our hands, rub them together thoroughly, and feel dry. By the way, we should avoid touching eyes, nose, and mouth with unwashed hands. That's something that we do remember all the time. The second what to do is named mistakenly social distances, which was not a good terminology for it, and it's better to use the physical distances. With the people who are sick, even inside your home, we should have social, or it's better to say physical distances, maintaining 6 feet apart with the sick and other household members. So keep distance between yourself and other people outside of your home. Remember that some people who hasn't any sign and symptoms may be able to spread virus. So stay at least 6 feet, about 2 arms length from other people. Avoid mass gatherings. That's something that we have to do. Stay out of crowded places and avoid mass gatherings. Keep distance from others, especially those who are at high risk of getting very sick. The other what to do is covering mouth and nose with a cloth face cover when around others. We should, maybe anybody could spread COVID-19 to others if even they will not feel sick. The clothed face will cover mouth and nose and prevent of spreading the virus and break the chain of spreading the virus. Do not use a face mask meant for a healthcare worker. The simple mask or even from simple clothes, it will be useful. The clothed face cover is not a substitute for social distances or physical distances. Everyone should wear a clothed face cover when he's out in public. As grocery store or market, which are usually crowded. When we should avoid clothing face or avoid covering face for children under age 2, because covering face maybe will cause some problems in receiving oxygen. Not those who suffer trouble breathing, not on those who are unconscious, incapacitated, or unable to remove the mask without assistance. Usually they are in high risk category. And when we are coughing or sneezing, we should cover our nose and mouth, even by mask or our inside part of elbow. If we are using tissue, the tissue should be in trash, then we should wash immediately hands. And if we don't have soap and water, we can use sanitizer, which will have at least 60% alcohol. The other what to do is clean and disinfect. Clean and disinfect frequently touched surfaces daily, as tables, doorknobs, light switches, countertops, handles, desks, phones, keyboards, toilets, faucets, and sinks. Clean dirty places by detergent or soap and water prior to disinfecting them. Use a household disinfectant, most common EPA, it will work. The other what to do is monitor your health. Be alert of symptoms. Watch for fever, cough, shortness of breath, or other symptoms of COVID-19. Especially important if you are running essential errands, going into the office or workplace, and in setting where it may be difficult to keep a physical distance of 6 feet. In this category, take your temperature. Take your temperature if symptoms develop. Do not take your temperature within 30 minutes of exercising or after taking medications that could lower your temperature, like acetaminophen. We should follow CDC guidelines of symptoms developing. Take home message, COVID-19 is much more than a health crisis. It has the potential to create devastating crises as social, economic, political. The COVID-19 pandemic is an absolute disaster and will leave deep scars. Everybody has a critical role to cut the transmission chain. These are useful links for further readings. They all are uploaded in the website, and the audience can use them. Also, they are references, and thank you very much for your attention.
Thank you, Dr. Alice. It was a great knowledge sharing session, and you highlighted how to actually break the chain of this COVID or coronavirus. Yeah, so our next session will start soon, but before that, I would again recommend and highly request our attendees to make it more interactive by asking questions. The more asked questions, I think we have great experts here. They have great experience, so they would actually share with you their best experience, best practices. So I can give 1 to 2 minutes here if you have any particular questions, and anyone would like to, use voice or mic, just raise hand, and we will allow you to unmute, and you could ask directly to our facilitators your questions or your concern.
Yes, if there is any questions in question and answer session, we will answer.
Because according to schedule, we have still 8 minutes for you.
So I talk rapidly.
Yeah. So that's why I'm allowing and taking this opportunity to let's have an interaction with our audience.
Yes, that's a good opportunity. I agree with you.
Anyone who would like to ask questions, just raise hand and I will unmute. How about from panelists? If you have any questions or you would like to know more, you could ask. Panelists can unmute themselves. Yeah, there is a question. Is there any relationship between myocardial infarction and COVID-19?
Yeah, Dr. Baluchi, is my voice clear?
Yes, yes,
yeah,
but you need to speak a bit loud.
Okay, I'll try to. So my opinion is if we could just finish the session as the presenters go on and finishing presenting the whole thing about the COVID-19, and at the end we answer the questions. What do you think?
Yes, it's a good suggestion, but we have still time for presenter.
Okay, yeah. Maybe we just move this time to at the end of the session, so we would have more time at the end for questioning and answering. I think people would have more questions by the time that they all get more information about COVID-19. And it's your call, sir. I just wanted to weigh in to tell you my opinion.
I thought you were going to ask a question.
Okay, cool. Thanks.
No worries, no worries.
Yeah, I have something to talk about, but I wait to the end to see if something has left out.
Sure.
I'll continue on that.
No worries, no worries. Okay, thanks. Thanks for your suggestion.
No
so may I request to answer this one question first, and then we'll move on. Is there any relationship between myocardial infarction and COVID-19 heart attack? Couldn't hear from you. That's what I read from the chat. If I think panelists also could see in the chat, and anyone would like to answer? Yes. Yes, Dr.
Myocardial infarction and some other cardiac complications are seen in about 10% of the patients in some papers. And the most common complication of COVID-19 on heart is myocarditis. And in some patients, we have, in papers, they reported myocardial infarction also. And also when we look at the records of our patients here, we can see some reports of myocardial infarction among patients with COVID-19 here.
Okay.
But I don't know exactly the mechanism of infarction, but it has seen in some patients.
So I hope Dr. Nafisa, you got your answer, right? But that's what you were looking for. Okay. Any other question? If not, then we'll move forward to next session. Yes.
Okay. No worries. May I say something?
Your voice is very low. May I know who is this Dr. Amir Hossein?
Yeah. I'm Amir. I just wanted to continue on the question you asked just from my own experience, if you don't mind, if you still have time.
Sure.
Okay.
Can we still have time, actually?
So yeah, from what I've known, working closely with other staff in hospital, dealing with this matter, taking care of patients diagnosed with COVID-19, I think there is still a lot we don't know about the disease. Some patients have underlying disease, heart problems from the past, and their symptoms, I think their heart symptoms get worsened worsen over time. I think we don't know to what extent this virus can affect your health. And if you have previous illness, I think that can get triggered and can be worsened. We still are not sure what this virus has to do with the cardiac system, but there are evidence that people with underlying diseases get severely sick and they may even lose their life. So I just wanted to say there is still a lot to probe.
May I, excuse me, may I request all those who are not speaking, could you mute your mic? We got a background noise.
No worries.
Thanks.
Is it okay now?
Thanks. Yeah, it's okay now.
Yeah, I just wanted to say there are evidences that people with previous diseases can get the symptoms more severely, and they may lose their life even, and that's an unfortunate thing. I think that my answer is, I think according to the news and the work of scientists reported in national news, and I think there's still a lot to be discovered, and we're not sure. But of course, people with diseases with a history of cardiac problems, you're at more risk to develop, I think, worse symptoms and unfortunately losing their life. So of course, there's a relation between these two, in my experience and to the extent of my knowledge. Thank you, Doctor.
Sure. Thanks, Amir Hussain, for sharing. Yes, please.
Hello.
Yeah.
Thank you for all. I'm Dr. Karim from Kurdistan region, Iraq. My question is about the protocol of treatment. You know, till now, there is different protocol in every hospital. They use the special protocol. So, what is your comments or opinion about the final protocol for treatment COVID-19? You know, COVID-19 is till now it is an infectious disease, and the sources of infections, it is unclear till now. So what is the final protocol for treatment?
As I, excuse me, may I answer this question?
Yeah, sure, go ahead.
As I mentioned in my presentation, there are different medications, not just care, oxygenation and ventilation, mechanical ventilation. These are the treatment for care of the patient and for reducing the inflammatory response. But about the drugs and medications, there are some studies that shows till this time, that remdesivir has some good effects. For example, the outcomes in the studies are less mortality from other in comparison to other drugs. But now some drugs such as hydroxychloroquine, that we used it for example, February or in the first months of the epidemics, hydroxychloroquine has so many adverse effects. And the most important effect of hydroxychloroquine, when used especially with azithromycin, the most important effect is on heart. So now, till now, remdesivir is an antiviral drug, and the RCTs shows that it's better than others on reducing the mortality.
Okay, thanks, Dr. Mashati. There are a few more questions, and I would ask all panelists, they can reply in the chat, and we'll move to our next activity. And I would like to invite Dr. Elias. Elias will be the facilitators for next session, that is a preliminary for Q&A. And Dr. Sadeh Ghafarifar, okay? Hopefully I pronounce your name correctly, right? So please, unmute Dr. Elias and Dr. Sadeh, and we can start our next session.
Dr. Bukhari? Dr. Bukhari, this is Amir. I just wanted to say if we have time for the next, I think, next one to be prepared for talk, I wanted to continue on the answer to the last question. Okay, so we continue.
Yes, since we are searching the appropriate PowerPoint slides. So meanwhile, you can answer, Amir Hussain, you can answer in the chat if it's possible.
Okay, yes. Oh, in the chat or why voice?
Yeah. I mean, I would prefer in the chat because let Dr. Elias set up a presentation
I just
and then.
wanted to use the time to just continue on the matter, but if you say, sir, it's better in chat, so I'll continue on that.
Thanks for understanding.
So I think we have still time. If you don't mind, I'll continue talking, and they will stop me when they're ready. How about that, sir? Dr. Bukhari? Okay.
Dr. Elias have to tell whether she's ready or not.
Yeah, I think she needs, a couple of minutes. I think there's something with the slide, so I'll continue.
Okay, go ahead then.
I just wanted to use time. So that was an excellent answer. That was an excellent question, and thank you for Dr. Alizade's answer. I think that's the question all of us are having. So what's the treatment of this disease? To my last update of news, I think the last thing I was following, there are 24 companies and centers all around the world that the staff are working together. I mean, crazy hours. They are all trying to discover something, discovering in the matter of finding the disease, finding the vaccine for the disease, an effective vaccine, or a drug or a cure to this disease. So there is no definite treatment to this. All we are doing is just symptomatic controlling of the disease. So there is still no cure for this, and all the staff in hospital are doing, and from what I've been witnessing, they are all working together to just soften up the symptoms and just help the patient. I mean, controlling the airways, tubing, and oxygen therapy. They are all controlling the condition and helping the patients to, continue breathing and not having problems in their pulmonary system. That's what they've been doing, and using anti-inflammatory drugs. But we all know that they are not the cure, and we are just doing our best to just control the disease and just save as many lives as possible. I think, yeah, that I can continue, but let's check if our panelist is ready. Thank you for this chance, Dr. Bukhari.
If there's possible, I want to speak for a moment. Mr. Khanepeza is one of our nurses who worked in a COVID-19 caring centers and in a ward that these patients hospitalized. I want I want him to speak about his experiences of that work and share these experiences with our audiences. Thank you.
Yes, thank you. I just wanted to double check with Dr. Bukhari. Dr. Bukhari, are we on schedule? How much time do I have? Dr. Bukhari? I'm just going to contact doctor in the chat to see how much time I have to continue.
Amir, can I correct you? It's Hasnain who's conducting it. Hasnain is moderating. Bukhari, like me.
Okay, so Dr. Hasnain.
Oh, okay. According to the schedule I have, this is a time for Q&A. Plenary facilitator is Dr. Elias.
Yep.
So if she's ready, she can start, and Dr. Saade.
Okay. Yeah, I'm just ready for the permission to talk.
Amir, can I suggest wait your time, let Hasnan do it. Your time come, okay. Hasnan will announce, okay? No worries. Just let him do. Yeah, yeah, just wait, okay?
No worries, no worries.
Yes, so Dr. Elias, do you have any issue, any problem?
No, I'm sharing.
So
there isn't any problem with sharing.
No, we could not see your slides.
Me?
I think Hussain Baloch, you continue, I think.
So, yes, you can start your session. Your session is now a plenary for Q&A. Please.
Yes.
Thanks.
I'm expecting our audience's experiences to be shared, listening to them. Then I will ask Mr. Khanepaza to share his experiences of caring from COVID-19 patients.
Dr. Bukhari. Oh, sorry, Dr. Bali. I get confused with names. I haven't had the chance to practice them. So Dr. Bali, if it's okay with you, Dr. Alice has given me the floor to talk about the experiences I've been having with patients suffering from corona.
Yes, Amir Hussain, please go ahead.
Okay,
yes.
Thank you, Mrs. Shifa. Okay, thank you for giving me this chance again. I hope my voice is clear. Can we all agree on that? Mrs. Shifa, if you could.
Yes, we can hear you.
Okay. So what I've been meaning to say, so about the experiences, I have a topic to talk about at the end when I think, which I think it's not spoken oftenly about. But before that, about experiences I've been having working with the healthcare team in the hospital. I should say there are lots of aspects of this new situation. Of course, this is a new thing. Nobody can say I'm really experienced on this matter. We are all learning, no matter how many months we've been working with these patients. So there are several aspects. As I've mentioned, there is no treatment. We all know that. There is no definite cure for this disease. What we've been doing, we are controlling symptomatic and symptoms and signs. That's what we've been trying to do. So in dealing with patients, I mean, it is very necessary that we assess them frequently because their condition may change very quickly. So in 1 minute, they are feeling okay. and the next minute they are struggling to breathe. So what matters the most is checking on them as many time as we can. So doctors are doing their rounds and they just check on them. I mean, even few times a day, because it's a different sort of situation. It's not like the patients in different, parts, different hospitals that are being treated for different diseases. In this disease called corona infection, they need to be checked over and over by doctors. And as nurses in the hospital, what we've been intending to do is to taking notes. What symptoms they develop suddenly? What are they talking about? Like we ask patients, do you feel comfortable? What do you feel? What's the new? What's the new condition of you? Like they go like, okay, my respiratory is fine, but I feel like pain in my abdomen, or they have problems in their digestive system, or they might develop other symptoms that are new. I think maybe due to the mutation in this very weird virus that we are dealing with at the moment. So there are still a lot to learn, and what we do is recording all the information about these patients is very important, because it is not only about the patients, it's really helpful for the future, researches, and for, referring and like transferring this data to other centers so they could just decide what to do next. So they may come up with different guidelines to control this issue. So the experience goes like, so it is a different life for everybody, and for nurses especially, and doctors, and all the healthcare system workers and all the staff. The protective suit we wear, the gear, protective gear, all of this has really made working there really difficult, because once you just put those suits on, you start sweating, you feel really uncomfortable, you're irritated, and even just taking a simple note, like taking notes with those thick gloves, it's really hard to write. And the problems I've been having several times dealing with those patients is that I just give you something. I tried several times. I was to just doing a cannula, venous cannulation, IV line. I tried that for maybe 4 or 5 times, but at the end I was successful. But the problem was I couldn't just find the vein by just touching the patient's hand, by palpating. That's really difficult, because through these thick gloves, your touch system, like your touching sensitivity, is really low, and it's really hard to find the proper vein to operate on that and do the IV line. So, and the patient, that was really surprising. The patient was really acting, I thought maybe he gets angry, and he said, I understand how hard this might be for you. So the understanding that we have from each other, patients and nurses and the whole workers, it's not like you're working anymore. It's like really we are helping each other out. Of course, they understand the risk all the staff are taking into working long hours. We work 6 hours. We cannot drink or eat, because we're gonna need to use the restrooms, and we want to save up as many protective suits as possible. So during the 6 hours, they know how difficult it is for us, so they understand and they cooperate really. And another, I think I can continue about the emotional part of our job in these days, but I just wanted to double check if I still have time. Dr. Baluch, your call. Dr. Baluch, okay.
If you let me, Mr. Khanepaza, I want to mention a point that I've seen many nurses who worked in COVID-19 patients. They were really exhausted because of wearing that suits, and it's really hard to work with that clothes and tolerating that situation. Also having fear of not being contaminated with the disease, not to transmit this disease to their families. So there is a global fear of being infected from the disease, which is really harmful. Besides, lack of information maybe was one of the challenges of that wards, because suddenly we faced to an unknown viral disease that we don't know many about it. I think what I've mentioned were the challenges of working in that wards as well. Are you agree with me, Mr. Khanepaz, as a nurse who was working or who is working still in that wards?
Okay. Yes, of course. I'm in full agreement with you. And if I still have time, I just wanted to add to a very important aspect, our jobs, if you don't mind. I continue until Dr. Baluch, sorry, stops me. So another thing I wanted to share with you, which I think is really important, is that just put yourself in patients' shoes for a moment. Patients who are suffering, really having tough days in the hospital, and all they are hoping for is to go back to their family. They are isolated. They cannot leave the hospital. They wish they could just leave the hospital for a few minutes to just get a fresh air, but they cannot. And what do they see every day? They see us, people in protective suits. They all look the same. They are all working long hours. They are always tired because, you know, when staff go back home after long hours and really heavy workloads, they all collapse and they just collapse and sleep to the next day, and they could just come back and work again. So what the patient sees, the environment of the hospital is all people is the same suit and the same uniform. They're all working together for him, and they understand our tough mission, and they know what we are intending to do to save lives, of course. I think the most important part of our job these days, I mean, apart from what we do to keep them safe at the hospital and all the caring we do, which is our duty as nurses and other staff in the hospital, it is emotional support of those patients. So what we do is we talk to them, communicate with them as we all do with all sorts of patients. What with these patients, they're desperate to hear a voice. They've been there for days or weeks even, and they are desperate just to have a talk, just a normal talk, just apart from the COVID-19 talk, apart from all the symptoms and all the difficulties, all things, everything they've been through. They just want to talk about how they feel. They miss their families. They just want to talk about that. The activities they're missing to do. They miss like going, I mean, camping. They miss to go just have like a day, camping day with their family, or just for a walk, or just they going back to normal life. They all ask, hey, would I get back to my normal life? Of course, we try to calm them down, but we tell them like we try to tell them that we are living in a different days. We are living in a different era. According to WHO, we cannot go back to normal life in foreseeable future. We're gonna live with this virus. We have to deal with it in ways we can. We are not to just leave. I mean, sometimes the quarantine is lifted very early, and that causes rapid rise back in the number of cases. So I tell the patient.
Sure. Sorry, I have to
No
interrupt
worries.
here.
Yep.
Okay, thanks
I'll
for sharing.
continue on this in the next
Till,
Thank you, Dr. Balu.
thanks a lot. Thanks a lot.
No worries.
There are a few more from our attendees. They have issues they could not actually speak, but they do share in the chat. So I would just read one or two of them, and I have already posted in the chat. And if anyone other than anyone other than Amir who would like to actually share their experience, just raise hand and we will unmute you. So it's better to have different hospital or different nurses to share their experiences. You know. Anyone else? If not, then let me read one of the message by. So I have been in contact with patient with COVID and have to stay in bed. And just to say in reply to one of the questions that no relationship between temperature and severity of the disease. Okay, that was the question asked. And in my 1 month experience, I saw patients who underwent treatments such as chlorine and sorry to if I could not pronounce the correct medicine name, Calitara regime, exomycin, oxygen therapy. Some healed after 1 week and some exported to intensive care units. And I heard them dead after some days. It was a hard time for nurses who has a family at home whom they cared. They may bring them to disease or whom they scared. I saw patients who have no real family and they could actually stay at hospital because their family won't take them back at their houses. So these are the actually experiences shared by Tia Abasi. Yes. Anyone else who would like to share?
Can I say a word or two? It's Dr. Shabi Zaidi.
Yes, Dr. Shabi.
Thank you. Well, it's wonderful to listen to all the conversations and debates and discussions. And I'm very excited to hear Amir. He's a young Turk who's just reinvented the wheel. You're doing so well, Amir. I'm proud of you. Great to meet you. Wonderful. We need people like you. Young blood is always the best blood. Coming back to the question of experiences, I'd like to mention 2 examples of my colleagues here in the UK who went through COVID. And what a horrible experience they had. And the reason I'm sharing is because a lot of people have not seen COVID patients. But when you see or meet somebody who's been through it all, you know how intense, how difficult, how fatalistic this disease is. Dr. Sumar is a famous dental surgeon here. A lot of people in this panel and others know he's a great servant to humanity. He went through the whole cycle, complete cycle of COVID era. He went completely into a state of coma. He was ventilated for about 2 to 3 weeks and he came back almost as good as dead. Still recovering. So I spoke to him about 10 days ago, just for general discussion to find out how he was doing. He could hardly breathe. He still has to carry oxygen. And he told me something which is very strange. He said, drugs or no drugs, this experience is unbelievable. It kills you without actually killing you. So mentally, psychologically, emotionally, even language-wise, verbally, I mean, he's such a brilliant man, he's tending to forget things. So that's one experience. Second is a famous general practitioner in Kent, Intazar Hussain, also a great social worker. He went through complete cycle of COVID, all the manifestations that you see, including a ventilator and what have you. And his experience is even worse. He said he could literally see death hovering around him. So it is not a simple disease. Nobody knows exactly what the cure is. They're still working. Recently, Oxford University is very optimistic. They've come up with this new vaccine. They're thinking they'll probably start in September. Of course, Imperial College has also started its vaccine project, and there are lots of other universities. Rosalind Center, the famous center in Scotland, they're working on it. So about 19 different vaccines are being tried. I think they've been through phase 1 and phase 2. Now they're thinking of starting on patients exactly when, I don't know. But in Bradford General Hospital, where some of my family visit, they said that some of the patients were tried on medications, including what you mentioned, like dihydrochloroquine and even antiviral drugs and what have you. But the results are very inconclusive. So you cannot be dogmatic about the treatment just yet. I think the overall policy is that they have to find a vaccine before the flu season. The flu season in UK starts in September. And only this morning on television, they were showing that people of a certain age must get some get themselves vaccinated against standard flu vaccine to save themselves from the augmentation of a repeat bout of flare of COVID-19. Thank you.
Thanks, Prof. Shabi, for sharing your experience. Anyone else who would like to share before we move to next agenda in our workshop? Please raise your hand, and my team here would be actually giving you mic. Okay, so may I invite Dr. Parisa for her presentation? Yes.
Hello. Do you hear me, please?
Dr. Parisa.
No, go ahead.
Yes.
There's a guest that would like to speak.
Hello.
We move to the second agenda.
Sorry, it could be delightful.
Sorry, we will look at the time. We are already overshoot the time. So you just hold on, those who have a question or would like to share experiences. Let Dr. Parisa cover her talk, and then at the end, we'll allow you to. Okay, thanks. Thanks for your understanding, all of our attendees. Because we have a program, we have to follow that strictly. Thanks. Yes, Dr. Parisa.
Yes, I'm here.
Yes, please
Hello,
continue.
everybody. I'm Dr. Parisa. Hope you are in good health during this outbreak. I don't know what's happened. Okay. Let me start video. Is it okay? Can you see me now?
May I request others to mute?
Okay,
it seems like you have multiple devices in. There's an echo, you know.
Hello again. I'm
Yes.
Dr. Parisa. Hope you are in good health during this outbreak. In the following 30 minutes, I'm going to talk about community knowledge and health literacy. First of all, I will share some information about how community knowledge can increase control over the factors that define health, and then I will discuss about some activities to improve health literacy according to the literature. Okay. I don't know why. Okay, it works. As all know, preventing the further spread of COVID-19 relies heavily on informing and encouraging the population to adopt protective behavior. And this effort may be more successful if the advice from experts is combined with local community knowledge. And such an approach not only prevents stigmatization and fear-driven response among affected individuals, family, and communities that can hamper prevent effort, but also act as a powerful lever to enhance adherence and mobilize community engagement. In this way, health information education must be powerful to improve the community's health cognition and influence personal knowledge too.
Factors that influence knowledge include education level, information, culture, and experience. And health behavior is influenced by these factors too. Knowledge is gained from an individual experience or others, and you know that this causes someone to get additional information through the process of sense. Individual who know information will be able to determine and react to make decision when encountering a problem. And all these components are included in the concept of health literacy. And health literacy implies the achieve of a level of knowledge, personal skill, and confidence to take action to improve personal and community health by changing personal lifestyle and living condition. Health literacy means more than being able to read pamphlets and make an appointment. By improving people's access to health information and their capacity to use it effectively, health literacy is a critical empowerment. And I think improving health literacy in a population provides the foundation on which citizens are enabled to play an active role in improving their own health and engage successfully with community action for health. Moreover, push government to meet their responsibility in addressing health and even health justice. But public health personnel have generally assumed that knowing about the risk factor of infectious disease has always been key to controlling and preventing an epidemic infectious disease. But what is different with COVID-19 is that we live in an age when expectations about mastering health are higher than ever. And these advanced expectations met with another unique condition that, you know, never in human history has there been such an abundance of health information available from numerous, more or less trustworthy sources. So it's a problem. In this condition, for public to understand what public health experts and politicians say or try to convey pose a range of challenge. You know, making sense of COVID-19 news and official recommendation is particularly difficult given the current higher degree of knowledge or uncertainty on many levels. So a major challenge comes to how individual can integrate this sea of information into personal behavioral action, and so it's a very critical. In the other hand, the best scientific knowledge on COVID-19 needs time to grow, and particularly the understanding of the appropriate public health intervention are bounded by time restriction. Therefore, as difficult as it may be, health experts themselves are challenged to help the public accept uncertainty where it is a yet unavoidable fact. But rapid development of coronavirus into pandemic has called for people to acquire, apply health information and adopt their behavior at the fast pace. However, when COVID emerged rapidly, two aspects become striking. First, globally, health literacy is an important for prevention of communicable disease, as it is for non-communicable disease. And second, along with system preparedness, individual preparedness is key for solving complex real-life problems. In this pandemic, it is difficult yet possible to take a time to enhance health literacy because immediate action is required by governments and citizens. But there is an additional problem, and it is about recognizing misinformation and as a product of individual informing process. In this way, I think it's not bad to be familiar with two terms. Infodemic and misinformation. Infodemic means an overabundance of information, some of them accurate and some not, that make it hard for people to find trustworthy sources and reliable guidance when they need it. In this situation, misinformation and rumors appear on the scene along with manipulation of information with doubtful intent. And in the information age, this phenomena is amplified through social network, spreading further and faster like a virus. But misinformation is false or inaccurate information deliberately intended to deceive. And in the context of current pandemic, it can greatly affect all aspects of life, especially people's mental health. Misinformation in the pandemic can negatively affect human health, and many false or misleading stories are fabricated and shared without any background and quality check. So it is very crucial to be aware about them as a healthcare provider. Okay, but what about the strategies? What can we do? Literatures have categorized this strategy into 4 domains, and what healthcare providers, healthcare organization to do, and community-based approach, to have community-based approach, and collaboration with public health system, and what health care providers should do. About healthcare organization, as you know, health care systems are staffed by clinical workforce that can leverage its therapeutic relationship with patients to promote and track progress in community knowledge. And they should identify appropriate timetable moment for addressing misinformation, such as care transition or prescription of medicines and vaccination appointments, and plan appropriate health literacy intervention for each. And beside of this, it's very important to know that community health centers are sites with a great potential for promotion of health literacy and community knowledge. And about community-based participation, health organization and providers already intact with the population they serve, but supporting relationship with diverse community organization and non-medical services agencies will support their position in communities and open new opportunities for information exchange. For example, community targeted forum can can be organized in locally important venues such as churches, recreation centers, and so on. And about cross-sector collaboration, as you know, in the current crisis is a prime opportunity. The current crisis is the prime opportunity for healthcare and public care professionals to build on their growing heritage on collaboration to partner once more and joining forces now to combat the misinformation that threaten the health and well-being of individual and population alike. Experience about Ebola epidemic in African countries showed that in an environment of trust, community partners can help to improve the understanding of disease control protocol and suggest moderate changes and better reflect the community's sensitivities without compromising safety. And about individual providers, I want to talk about results of a research. 2 years ago, Gallup poll found that 84% of Americans rate honesty and ethical standards of nurses as a very high and or high. And making them the most well-regarded professionals among those considered. And doctors ranked second at the 67%. Another Gallup poll conducted this March in the middle of the COVID-19 pandemic and produced similar findings, and showing hospital and health agencies to be the most trustworthy of the 9 major nature institutions and leaders proposed. Despite this privilege, social regard, however, many four-line providers remain unaware of their patients' beliefs because they never ask. And the notion of personal explanatory model of illness refer to a patient's representation of disease and based on beliefs, emotions, knowledge, and experiences that are grounded in culture. It's important to know that what patients actually do in the face of illness is often a logical extension of their personal beliefs rather than of the scientific standards. So doctors and nurses must recognize that understanding patients' belief is the starting point for engaging them in decision making and help them to improve their health literacy. But some points that are very important to know about them in share information with community is that it's very important to know that individual knowledge about COVID and maybe overall about health problems will depend upon individual race, sex, and age. And studies showed that Black people, males, and individuals younger than age 55 were less likely to know how the novel coronavirus spread and the key symptoms of the disease. Meanwhile, ethnic minorities are not only experiencing COVID-19 outcome disparities, but are oftentimes also left in the dark for public health education. And we have to be aware about them, and it's very important to care of them. And moreover, it's important to know that public health priorities do not always align with community priorities. And the success of public health effort often depend on having a plan to address community concern. For example, in this outbreak, mid-March post showed that the public was keenly interested in safety of visiting outdoor recreation area. However, CDC did not pivot to messaging on this topic until around April. So it shows that we are not adopted with with community priorities, and we have to think about it, and maybe we have change our approach. Another thing is about public health messages that are very important, and especially during a pandemic. But most of the messages is too narrow in its breadth. And for example, population with vision and hearing impairment are often neglected via other messaging modalities. Just to recap on what we've discussed, I think an important lesson to be drawn from COVID-19 pandemic is that health promotion should not wait until a crisis happens, but prepare itself to respond swiftly. And to deal with a pandemic effectively, we must not only understand the virus and how they spread, but also the way in which people make decisions and organization operate and communities related in reaction there. Thank you very much for listening to me. And I want you to pay attention to the next topic presented by my dear colleague, Dr. Hassan. Thank you very much.
Is it shared?
Yes, we can see your slides. And we can see you also, and we can hear. Yes, please. Please go ahead. Dr. Mariam.
Hello, everyone. I'm very happy, and it's my pleasure to be here with you. My dear colleague explained about different aspects of COVID-19 pandemic, and I'm going to talk about stigma in COVID-19. I'm going to talk about definition of stigma medication, and public health responses, causes of stigma, effect of stigma in different aspects of life, and guide to preventing and addressing social stigma. First of all, I talk about a definition of stigma. If you search, you can find a wonderful and significant definition about stigma by Goffman. Goffman provided this definition in 1963 as an attribute which is deeply discrediting, that reduces a person from a whole and usual person to a tainted, abnormal, discounted one. Really, stigma can cause a dichotomy between being normal and acceptable versus being abnormal, tainted, and desirable. And we have a social stigma in health. This is not new, stigma is not pertained only just to COVID-19, and it is attributed to another diseases such as HIV, such as Ebola, and so on. Social stigma in health is the negative association between a person, a group of people who share certain characteristics and a specific disease. These people, social stigma in health means a group of people which experience a common pain, which experience a common disease. And this disease causes people are labeled, stereotyped, treated separately, and or experience loss of status because of this disease. About the main causes of stigma, WHO said three factors. The first one is COVID-19 is new and unknown. The second one, we are afraid of unknown. And the third one, it's easy to associate that fear with others. As you know, COVID-19 is a severely contagious disease, and it can accelerate the stigma related to this disease. And we have challenges. We have challenges between stigma mitigation and public health responses that I explain about this. For example, people are recommended for physical and social distancing in COVID-19 pandemic. And different governments have set different rules such as quarantine and travel restrictions. All measures taken by governments can affect and can accelerate fear from COVID-19. For example, in Iran, it's about 5 months that people are recommended stay at home and don't leave home unless for essentials. This is a new accident. This is a new concept for people in Iran and other countries, and this can cause fear and stigma. This can accelerate the stigma related to this disease. And the third one is misinformation that Dr. Buzorgzad say about that. Misinformation is information and data that are not correct and spread in the social media and can affect on people's view about this disease. The impact of stigma on different aspects of our life. The first one, intrapersonal impact. As you know, a person with COVID-19 feels isolated and don't accept it by other one. This is so crucial that others and healthcare providers understand these patients and their families. And in interpersonal impact, as you know, and my colleagues explained, this disease can influence relationship between people. For example, we mostly use social media and applications such as WhatsApp, Skype for our relationship with others. In social aspect, we can say some new social norms started in this pandemic. For example, at the moment, all of us should wear a face mask outside of our home. And this is not tangible and familiar for us. And the last one is the impact of stigma on a structural aspect. Every person for employment should give a COVID-19 test, and after that, the process of employment is done. And the impact of stigma on healthy behaviors of patients, that is so noticeable. People with COVID-19 hide their illness to avoid discrimination. This stigma prevents people from seeking healthcare immediately. This is so crucial because it can spread the disease. Discourage people from adopting healthy behaviors. This unhealthy behaviors is not useful and can spread disease in the society. And for policies and solutions for reducing this stigma, you can find a guide by WHO for preventing and addressing social stigma. I explained different parts of this guideline, and I gathered some information from different resources beyond it. This guide includes two parts. The first part of this guide is about how do's and don'ts in talking about COVID-19. And the second part is the role of governments, policymakers, and volunteers for controlling stigma related to this disease. The first part is how to talk about COVID-19, do's and don'ts. Talk about COVID-19. Don't hide information about this disease. Talk, but don't attach locations or ethnicity to the disease, such as Wuhan or Chinese virus. Chinese people are in severe and heavy distress in COVID-19 pandemic. Talk about people who have COVID-19 who are being treated or died, but do not refer to people with the disease as COVID-19 cases or victims, because this word has a negative sense and can accelerate the sense of stigma and labeling in these patients. Talk about people acquiring or contracting COVID-19, but do not talk about people transmitting or infecting others or spreading the virus, because it can cause a negative feeling and a feeling of blame for these people. Speak about COVID-19 accurately based on scientific data and latest official health advice. This is so important. Misinformation is not useful in this situation. Don't repeat or share rumors, hyperbolic language that generates fear from this disease. Talk positively and emphasize the effectiveness of prevention and treatment measures, and don't emphasize negative or frightening messages. We shouldn't show we are powerless against the COVID-19, and we should talk about this disease with emphasis on prevention methods. Stop another do's and don'ts from other resources beyond WHO. Support families, caregivers, and healthcare providers affected by COVID-19 with love and compassion. All of us, as a physician, as a nurse, as a healthcare provider, should provide compassionate care and empathic response to these patients and their families. Find innovative ways to meet with your family without physically being in the same place, for example, with social media. Take physically distancing seriously. Talk about people who have COVID-19, whether they were treated or died from the disease. It can lessen the fear from this disease. Do pray and practice the relevant use of scripture. Some religious activities, especially for Muslims, such as prayers, can cause a feeling of relaxation, and in this stressful situation, it's so critical for us. Don't share links from sources that are not trusted. People are recommended to follow the latest news about COVID-19 from reliable websites such as WHO. Don't share funny clips or photos with stigmatizing messages. Don't hide facts or use technical jargon. It's right of every patient, every people, to know about his disease, to know about details about the diagnostic tests, treatments. It's a human right, and it's our duty as a healthcare provider that present simple data without using jargon for patients, their families, and even in the society. Don't allow people to become isolated. Compassionate support while physically distanced. This compassionate behavior may be just a simple hand-holding of patients in this COVID-19 pandemic. Don't stigmatize those recovered from the COVID-19. They can't infect anyone else. And don't refer to COVID-19 patients with disrespect. It's all measures, even quarantine for example, traveling limitation, and every policies should be fully respectful of dignity, compassionate, empathy, and human rights. And this is so important. The second part of WHO guide for reducing stigma is the role of governments, community, and the media in stopping stigma. These solutions have different aspects, spreading just the facts, engaging social influencers, amplify the voices, portray different ethnic groups, and the last one, ethical journalism. Social media has a pivotal role in spreading correct information for prevention and treatment. Social media can influence on knowledge of people correctly, and it inhibits incorrect and misinformation in this situation. Governments should help from religious leaders, celebrities, or other important persons because people love these persons and can follow their recommendations. And these are the key people for education, health education to the society. Amplifying the voices. And what voices? Voices of volunteers. For example, we have seen different photos and videos about volunteers who participate in, for example, producing masks and disinfecting streets, schools, and offices. Governments should amplify the voices of volunteers, and most important, implementing hero campaign honoring caretaker and healthcare providers for appreciation of physicians, nurses that have a stressful situation in this pandemic. Different ethnic groups should be participated in showing different aspects of this disease. Typeface, symbols, and formats should be neutral and don't suggest any groups, especially for Chinese people. It's so important. And the last one is ethical journalism. In ethical journalism, say that we can focus on the prevention practices and symptoms of COVID-19. We should not focus on vaccine and treatment because speaking a lot about vaccine shows that we are unable, we are powerless against this disease, and this can cause a negative sense for the society. And the last word to sum up, infodemic is, as Dr. Bozorgzad said, it's a combination of information and pandemic. And it can cause negative effects on stigmatization. We prevent infodemic, and correcting misconception is so important for reducing COVID-19 stigma. Share sympathetic narrative with individuals or groups affected by COVID-19 for example, patients, their family caregivers. I think it's our duty to use empathetic behavior for these patients because they are in a stressful situation. Communicate support and encouragement for those who are on the front lines of this outbreak. As I said, volunteers, healthcare professionals, and community leaders. And this is some references that I used. Thank you very much for your care. My dear colleagues, Dr. Salehi said about the next topic.
Dr. Salehi, we are ready to hear you.
Yes, yes, yes. Hello, everybody. Can you my verify?
Yes. Mute, please. Mute.
I'm sharing my file.
Dr. Salehi. Yes, yes. She's connected.
Okay. I can't find a file in this sharing. Yeah. Do you see my file sharing or no?
So we can see your desktop, so you need to open your PowerPoint. Yeah, you already shared. Yes. Yes, Dr. Saleh, we could see your slides.
You can see? Can you see
Yes,
there?
yes, we can see.
Okay.
Go ahead.
صدام کمه. Do you hear me?
Yes, we can hear you loud and clear, and we can see your slides.
Okay, okay. Hi, everybody, everyone. I am very happy to participate in this meeting with you, of course, individually. And if you don't hear my voice or it's not clear, yeah, I could, this is better, yeah? Yes. I hope this presentation can help you to identify and deal with the psychological problems caused by the disease. My name is Tahmina Salehi. I'm a faculty member in Iran University of Medical Sciences in Nursing and Midwifery faculty. In this presentation, I explained about promoting nurses' self-care, emotional and mental well-being. And I explained content of this presentation is introduction to outbreak of COVID-19 briefly, COVID-19 in Iran also briefly, COVID-19 and nurses, a warning sign of extreme stress, impact of COVID-19 on emotional and mental well-being, COVID-19 supporting nurses' psychological and mental health, institutional support, and another support by self-care strategies, and take care of yourself by some tips. In the end of my presentation, I introduced the self-care package for nurses that prepared by American Nursing Association about COVID-19 in 2020. For introduction, I can say in January 2020, WHO declared, declared the outbreak of a new coronavirus or COVID-19 to be a public health emergency of international concern. And after that, in March, the WHO made the assessment that COVID-19 would be characterized as a pandemic. Globally, until now, until 22 July, there have been about 14 million confirmed cases, unfortunately, of COVID-19, and that include about 600,000 deaths that reported by WHO. In this link, you can see geographic distribution of 14-day cumulative number of reported COVID-19 cases per 100,000 population worldwide. The worst countries, as you see, were marked in dark brown. And this is a huge country. This is many countries, unfortunately. In Iran, in February 22, the first sample test was confirmed as positive for coronavirus in Masih Danishvari Hospital. This hospital is the reference center in Iran for all pulmonary and respiratory disease. And in this I can say about this that the result of a study conducted in this hospital on about 300 nurses at the Masih Danishvari Hospital, most of samples had severe PTSD symptoms. PTSD, it means, post-traumatic stress syndrome, stress disorder. And COVID-19 in Asia have about 3 million cases, and the 5 countries reported most cases: India, Iran, Pakistan, Saudi Arabia, and Turkey. And in Iran, we have about 300,000 positive cases, unfortunately. I explained some explanation. I have some explanation about COVID-19 and healthcare worker. Frontline healthcare workers treating patients with COVID-19 are possibly exposed the highest risk of infection because of their close contact with many suspected or confirmed patients, and even they may have to work longer hours than usual. The coronavirus pandemic will have a psychological impact for healthcare workers, which could be sustained. Frontline workers will be particularly at risk. There is a clear need for immediate action to safeguard the welfare of the health and care workforce. Action are needed to mitigate the impact of this disease on mental health by protecting and promoting the psychological well-being of healthcare workers during and after this outbreak. It is crucial understanding the psychological impact of COVID-19 pandemic among the frontline healthcare worker. Protecting them is an important component of healthcare measure to deal with this global pandemic and needs urgent attention. These resources of actually psychological and mental disorder. Nurses are at risk emotional strain and emotional stress and physical exhaustion from one of these resources is the provision of care to growing number of patients who many then rapidly deteriorate. For example, one of chat, I saw that he explained, or I don't know, she explained, I was a corona unit nurse for 1 month. I am 1 month experience. I saw patients who underwent treatments such as chloroquine, such as azithromycin, oxygen therapy, and some healed after 1 week, and some exported to intensive care unit and heard them dead after some days. It was hard time for nurses who has a family at home whom they scared they may bring them to disease. In this chat show that the provision of care and provision of DL nurses to patients who maybe died, it is a very, very bad experience for nurses. Another sources of mental distress is the nurses may be exposed to critical illness or death of their co-worker. Unfortunately, we have a significant number of nurses and physicians that pass away in these months. And they may also face moral dilemmas in decision-making around provision of care with limited resources. Limited resources is a universal issue in the worldwide, and this is a source of strain and dilemma for nurses and physicians. Stress and anxiety and depression may be viewed as a normal emotional reaction in the face of pandemic. Another reason is fear around COVID-19 exposure. They are worried, nurses and physicians worried about themselves getting infected or infecting their family members once they return home after the work. Another reason, that's another source of emotional strain and emotional physical exhaustion from this category. Anxiety related to shortage of personal protective equipment. And this is another worldwide issues that we have shortage to personal protective equipment or PPE. The challenges of family support and child care while they work. Because of the majority of number of nurses are women, and they have responsibility about child care and about care about their family. They may experience irregular hours and higher workloads, coupled with anxiety as they enter new or unfamiliar clinical roles. Healthcare workers are also affected by the stigma related to the COVID-19 virus and its impact, which was fully and well explained by my colleague, Dr. Ehsani, in the previous session. The study, one study that was done in the China showed that a healthcare worker in the insomnia group had more psychological problem. It is impact of psychological and mental distress and stress that it can cause insomnia. Protecting the mental well-being of healthcare workers caring for people with COVID-19 has been identified as imperative for the long-term capacity of the healthcare worker. In particular, providing psychological support to frontline workers is noted to be significant public mental health challenges. Fear or stigma of asking for help can prevent nurses, physicians from requesting support if they experience psychological stress, that it causes worse the situation for them. It is crucial to understand the psychological impact of COVID-19 on the frontline healthcare worker. The overall well-being and resilience of nurses are key determinant to maintain an optimal healthcare response for appropriate patient management as well, so to achieve good outcome. This is a 3 nurses in quarantine in Janvier 28 in East China, in Shandong, that protect each other and hug each other for support themselves. Impact of COVID-19 on emotional and mental well-being. During the COVID-19 pandemic, nurses are experiencing pressure, fear, exhaustion, isolation, and ongoing emotional trauma. This ongoing stress and trauma impact their mental health, safety, and ability to provide the best possible care. taking steps to manage the stress is just as important as taking care of physical health. In this slide, you can see a warning sign of excessive stress in 4 categories. In cognitive category, this sign consists of difficulty thinking clearly, disorientation, confusion, difficulty to problem solving or decision making, memory issue distortion, misinterpretation of situation and component. And in emotional category, warning sign as fear of terror, perceived danger, anger, hostility, frustration, irritability, and so on. And in behavioral sign of excessive stress or extreme stress, it consists of risk taking, failure to use PPE, refusal to follow orders, and increased use and misuse of drug or alcohol, reduce ability to support peers and conflict with others, and withdrawal and isolation. And in physical category, we can see rapid heart rate, palpitation, muscle tension, headache, tremor, gastrointestinal issue, nausea, inability to relax, trouble in sleeping and insomnia, flashback, and high adrenaline in his or her blood. Psychological and mental stress of COVID-19 on nurses, and recommend various strategies. Both institutional support as well as self-care strategy play a vital role. That explain about it in another slide. Institutional support that can used by managerial system consists of research has identified that healthcare professionals have requested 5 things from their employee during the COVID-19. Hear me, protect me, prepare me, support me, and care for me. So the management of healthcare institutions should be in contact and also meet up with healthcare workers to understand their needs and also to discuss the importance of stress management and psychosocial support for the workforce. Another responsibility of manager in the healthcare institute, psychological support could include counseling services and development of support system among colleagues. Every healthcare worker should be aware of where and how they can access mental health and psychosocial support services, and the hospital should facilitate access to such services. Another responsibility of manager in this area, as the pandemic evolved, important strategy and policies and departmental and institutional and national level are needed to support healthcare workers, especially physicians and nurses who are susceptible to psychological disorder. At national level, government should educate the general public regarding the myth and danger of stigmatization, and healthcare workers who are tirelessly work to combat the pandemic. A recent COVID-19 study demonstrated that frontline nurses had significantly lower traumatizing score than non-frontline nurses and the general public. Another category is self-care strategies that can be used by all of nurses and physicians that are frontline of healthcare. Coping strategies at work, including brief relaxation breaks during shift, working in teams, partnering in experienced or new staff with the experienced colleagues to provide support, monitor stress and reinforce safety procedures, regular peer consultation and supervision, seeking out accurate information and mention to assist in making decisions and talking to colleagues to share work experience. And after the shift, they should ensure adequate rest between shifts, scheduling time of work for gradual reintegration into personal life, eat healthy food, engage in physical activity, and stay connected with family and friends via telephone, email, social media, or video call. And they should avoid using negative coping strategy. Negative coping strategy consists of, for example, use of tobacco and alcohol or other drugs as they interfere with sleep cycle and worsen insomnia and associated stress. Self-care tips suggested by Royal College of Nursing, it consists of make sure you are getting your news from trusted sources. Limit your exposure to social media if you find it is heightening your anxiety. Think self-care, sleep, routine, and rest. You may find yourself working longer or more shifts, so take care of your physical health as best you can. Stay connected to family and friends by phone, email, and another video calls and another routes. Check local arrangement for key worker child care plans in your area. You can see some alarms. Yeah. What is it? I can continue? Can I continue?
Yes, your time almost up, but you can continue. Try to conclude.
Okay, thank you.
Thanks.
You're welcome. And the tips for managing your stress: acknowledge and understand your reactions, be aware and monitor your well-being, activate your parasympathetic nervous system to combat stress, and take time for your mental health. Tips for positive mental health during COVID-19 pandemic: do something and don't something actions. Do these actions: positive thinking, regular exercise, balanced diet, relaxation exercises, regular daily routine, socialization, online, of course, and virtually, of course, taking a break from a routine work life, other healthy lifestyle measures. And don't activities. Substances use, eating too much fast food, excessive online activity, excessive watching TV, mostly news, mostly bad news, partying, travel, focus on the negative aspects of COVID-19 pandemic, posting about COVID-19 on social media and spread fake news and believing fake news. That is very, very bad act. And take care of yourself in summary. Try and use helpful coping strategy, such as ensuring sufficient rest and respite during work or between shifts, eat sufficient and healthy food, engage in physical activity, and stay in contact with family and friends. Avoid using unhelpful coping strategies such, I explained about that, tobacco, alcohol, or other drugs or drug abuse, and using strategies that have worked for you in the past to manage time of stress can benefit you now. You are most likely to know how to de-stress, and you should not be hesitant in keeping yourself psychologically well. This is not a sprint, this is a marathon. It means that we can deal with this disease steady and for, I don't know, for 3 months, 4 months, 6 months, 1 year, and another. And this is some advice for team leaders and manager. This advice consists of keeping all staff protected from chronic stress and poor mental health during this response means that they will have a better capacity to fulfill their roles. Ensure good quality communication and accurate information updates are provided to all staff. Rotate workers from high stress to low stress functions. Facilitate access to and ensure staff are aware of where they can access mental health and psychosocial support services. Orient responders include nurses, ambulance drivers, volunteers, case and identifier, and so on to works in quarantine sites and workers in quarantine sites. Manage urgent mental health and neurological compliance, delirium, psychosis, severe anxiety or depression with emergency or general healthcare facilities. And ensure availability of essential generic psychotropic medication at all level of healthcare. And finally, apply strategies to identify and intervene with nursing mental health concerns while decreasing the stigma associated with mental health conditions. In this slide, I introduce a self-care package for nurses that prepared by American Nursing Association about COVID-19. And in this package, key learning outcomes is recognize moral distress in your nursing practice and build confidence in confronting moral complex situations to reduce moral distress and burnout, self-identity ways to build moral resilience and reduce this physical and emotional consequences, identify the most common ethical dilemma in nursing practice, harness expert tips and strategies to build resilient teams, establish leadership responsibility for identifying work environment elements contributing to fatigue, define leadership strategies to create and sustain a safe care delivery environment, and finally apply strategies to identify and intervene with nursing mental health concern while decreasing the stigma associated with mental health conditions. This is a very good package, and I advise use of it if you have this psychosocial experience. My presentation is end, and the references is here, and I am ready to answer any question, and I'm here for these your questions. Thank you very much for patience and for hearing to my presentation. Thank you.
Thanks, Dr. Saleh. It was really great experience. And I think I should salute you and your team and all nursing staff. And may I know Atia Basi, she shared great experience. I could not even read, I was feeling like tears coming out of my eyes, She mentioned it is a common sentence in most co-workers. I'm not scared about catching the disease or diseases myself. We are scared of being the reason of our loved ones catching disease and harm them in any case. So in that case, who can forgive us? I have no comments. Anyone who could actually add?
Yeah, Dr. Baluch, may I introduce our next presenter?
We are still taking questions, Amir Hussain.
Sure. When that was the time, you let me know and I'll go on with the introduction of the next presenter.
Thanks.
Thanks.
So if anyone who would like to ask questions can actually raise hand or post in the chat. Most of the questions actually already answered by panelists. And I would like to thank all the panelists. It was a very busy chat and discussion going on in the chat room. So if there's no question, then I would actually allow Mr. Amir Hussain to introduce the next speaker and next.
Baluch.
Yes.
Yeah, thank you, Dr. Baluch. We are having Mrs. Naqibi. She is currently holding the highest position of management in Hashemi Nejad Hospital here in Tehran. She has a very busy schedule, but of course she realizes that this is as important as her presence in the hospital. So she's giving us her time, and she's gonna talk about her knowledge on this matter. So we're gonna hear from her. So Mrs. Naqibi, if you can hear me, you can start in a few seconds. Mrs. Naqibi, if you have my voice, if you please just confirm.
Yes,
you have me.
yes.
Very good. So I'll mute myself and you start. Thank you.
Thank you very much. Hello, everybody. I'm Farzaneh Naqibi-Qaneh, nurse director of Hashim Nejad Kidney Center in Tehran, and I'm very happy to have this opportunity to share our experiences in HKC during COVID-19 pandemic with you, and I hope that was very useful for you. As you know, with the beginning of coronavirus outbreak, none of us were prepared for what came. But our head of hospital, Dr. Abbasi, was very, very sensitive to this crisis, and set out the managers and crisis sessions for predict some risks and also some preparation for hospitals and our personnel, and also for our tasks as a special hospital. You know that HKC is especially in urology and nephrology patient. We could design some plans and actions for managing the coronavirus outbreak, and we had many sessions in the hospitals, and we could establish a tent in the yard of our hospital, and we could conduct all of the people who enters to the hospital to these tents, and we could screen all of the people with temperature screening, and also if there is any symptom, we could manage them, and also maybe some of them self-isolated, self-care, and also the others conducted to the ward, and also we could use a doctor and a nurse in our tents, and screening and triage all of the people who in the points and points of the hospital, such as the emergency unit and outpatient clinic, all of the entrance areas. And we could recognize early recognition of patients with COVID-19 to slow and stop transmission. And we could educate the public to stay at home, and for people who are self-isolating. And all suspected patients were immediately isolated at home with following up by telenursing during 24 hours by our educational supervisor and our nurses in the hospital. Most patients were only mild, 40% were mild, and 40% moderate disease. Approximately 15% had critical disease, complicated, such as respiratory failure, ARDS, and septic shock. The risk factors were smoking, diabetes, hypertension, kidney transplantation, and hemodialysis patients for severe disease and death. We could fortunately screen all of the hemodialysis patients and with lung CT scan, temperature, and IgG test. And patients with a suspected, probable, or confirmed COVID-19 have been immediately isolated, and we could divide the ward in two groups, suspected or probable positive patients and negative patients. And we could hemodialyze those patients in different days and sessions. We needed to create a newly ward with a team of employees reassigned from other parts of the hospital and turning units into COVID-19 care areas to keep up with the stream of patients from emergency room and tent. And we could design the unit and providing all necessary medical equipments. To help ensure our personnel have the right personal protective equipment in our work setting, PPE was designed to protect them from infectious agents and prevent the transmission of infection between staff and patients. Hand washing, workplace cleaning practices also played important roles in infection prevention and control. We could provide gowns and coveralls, face masks, eye protection. All of them were provided for the personnel by very, very important effort of our head and our manager in hospital on those days. There are, you know, that these equipments was limited in the hospitals. We also had some educational sessions for teaching our nurses, our students nursing, and also physicians volunteering on the front line how to perform care activities and use PPE. These sessions were held by our educational supervisor and the also infection control nurse and supervisor. We should keep up to date with national guidelines issued by the government and the Ministry of Health, and we should up to date with these guidelines and also familiarize all nursing staff, including nursing associates and healthcare support workers, with the policies and emergency planning, infection control, and also prevention. Emotional support was very, very important for our nurses, giving nurses the opportunity to recognize their value and also worth in their work is the thing that sustained them on those very, very difficult and hard work. We had to provide emotional support and empathy for nurses seeing patients die. Those days was very, very terrible. We had to make sure our team had enough personal protective equipment and drinking enough water for prevention of dehydration for our personnel in those wards. Our nurses have taken the responsibility very willingly with their heart and soul.
They worked without any expectations and by sacrificing their personal life and family. And nurse managers and the role of nurse managers is very important. We need to embrace our role and take our place as the leader. Nurse managers should remain visible on the unit and help out with patient care whenever possible. We need to say, I'm here, let me help. We need to make nurses feel supported and that someone is there working with them, working with you. You know, how we speak and carry ourselves is always our most important management tool as a manager, as a leader. In spite of being always honest and transparent, nurse managers must be calm and focused on to help comfort team members. We need to deliver the truth and yet give nurses hope that they can get through this. That is always a very fine line to balance. This is a time when nurses are experiencing so much grief, loss, and fear. So it's okay to relax those boundaries a little bit. You know that this birthday of one of our colleagues in the COVID-19 ward. Every day around by our CEO and head of our hospital, Dr. Abbasi, and also me as a matron, and the other managers, our manager in the hospital, the supervisor. These everyday rounds was very, very effective for personnel and for nurses that we are beside them and they are not lonely. Emotional support for our patients also was very important. We could have some holy for patients, some gifts from Imam Reza and from Mashhad. We could give them some gifts from Imam Reza, and that was very, very effective for emotional support for our patients. And at last, our head could held a session for acknowledge our nurses and doctors' contribution in effort for combating for the COVID-19. And we could invite the head of a university and also the other important person to our hospital. And in this session, we could acknowledge our team, our nurses, our doctors, and the other one. This is the last photos on that day. And fortunately, there is no time like the present to celebrate and be proud of our rewarding profession. Thank you very much.
Dr. Baluch, I also need about 5 minutes to talk about a few remaining issues. If you don't mind, Dr. Baluch.
Sorry, I could not hear clearly. May I know?
I tried to speak louder. I need about
There's a lot of echo. Could you please
just
mute other devices?
Let me change my position, sorry.
So if I follow the program, the next item is actually a plenary or question answer session. And may I know Dr. Hamid? Dr. Hamid is around, and he could actually facilitate this session. If Dr. Hamid, could you unmute yourself? If he's not around, can I have Dr. Elias? to facilitate this session?
I'm here. Just my microphone was mute. I'm sorry. If you let us, I think it's a good opportunity to share the experiences of the managers. If among our audiences we have nurse managers, they can share their experiences of caring and managing the hospitals or the wards of care of COVID-19 patients. As Mrs. Naqibi said, her experience is very, very, organized and very thoroughly expressed. I think that's a good opportunity to listen to our audience's experiences as well. We have a few minutes for listening the experiences.
Sure, go ahead. May I know you could name the person who is going to talk or share experience, please? Dr. Elias, I need your help to name the person.
I'm hearing, but I think there is sorry. I think among our audiences, there have to be some persons who have experiences of managing these wards. If so, we can hear them or listen their experiences. If not, I myself have an experience of, one of my friends was the manager of a ward of COVID-19 patients. She told me that at first nobody knows what we should do about these patients. We think that that's a routine disease that we should just separate them, isolate them, and care them. But after a while, we realized that it is very infectious, and that's when the whole, preventive caring started. This was a crisis for all the managers. I think all the nurses who worked in these wards or all the managers who manage these wards have an experience of managing this crisis. But I'm really willing to listen to our audience's experiences.
Yeah, so may I request anyone in the audience who would like to share, just raise hand and I will give you a mic to talk. Just raise your hand or post in a chat. I would actually give you a mic.
I didn't get anything in chat. No question and no experience.
Yes, I have one, Dr. Mahmoud. I think let me allow him, give a mic.
Yes, sure.
Yes, go ahead, Dr. Mahmoud. You need to unmute
Hello.
yourself. Yes.
Are you hearing me? Hello, everyone.
Hello, yes, go ahead.
Hello, thanks a lot. Thanks for your vital information. By the way, I'm not working in a clinic. I'm a lecturer at the university. I'm a nurse, and I'm a PhD nurse student. I want to talk about some experiences that I have with my friends. By the way, I'm living in a country that's politically not stable, and people in this country, as the politicians participated and shared and enter to every feature in their life, still some people in our country do not believe the reality of that disease. It's meaning that for the life example, my mother still not believe that the disease is real, and even she's at a high risk because she was got on the lobectomy, but still she didn't perform any self protection. You have so many people like that. And there's another thing that I want to talk about, that there's some misdiagnosis in our, that I have seen here. Just about 2 to 3 hours ago, I was talking with my friend that he was sick for about 2 weeks, but still he was denied that he was got COVID-19. He said that I was before getting this disease, I did swimming, and then I was sleeping under air conditioner, and I had a high fever and a little bit of shortness of breath and tiredness, something like that. And doctor said that you will have COVID-19, but I don't believe it. I think that I have just maybe typhoid or muscle spasm, something like that. I mean that in this, there's different features of the syndromes I seen here. Someone that have just a mouth, and they say that the feature just like muscle spasm or something like that, but they didn't believe that it's a COVID-19, and they not got a confirmed diagnosis. I don't like, I not believe that. They said, I don't believe that it's a real disease, and it's not just a typhoid or something like muscle spasm. I mean that in this situation in our country, I think it's the cases will be rising dramatically, but the fatality of the cases is not high. That's all like a question. That there is a relation between this fatality and the weather that is too hot in our country, and just this effect of the virus decreased or not. I don't think so. Like that. If you have any answer about this question, for this question, I wanted to hear about. Sorry about that.
I need to check whether panelists got your question or not. Or could you repeat in one sentence or a few sentences only about your question?
Just the weather, as you know, previously WHO and other organizations said that within the changing the weather, the virus will be not active and the fatality will be decreased. But finally, that organization is also canceled this knowledge. But as I see here in our country, the fatality of the disease is diminished, and someone that affected with the virus, just they misunderstood and they misdiagnosed. They said that it's not a virus, just like a muscle spasm or something like that. Do you think that hot weather, the weather is affected that fatality of the virus or activity of that virus or not? That's my question. Sorry about.
Okay, thanks for answering and sharing your experience. May I ask any panelists who would like to answer? Yes.
I would like to weigh in, if you don't mind, Doctor.
Go ahead.
Okay, so that's actually a very good question about the effect of temperature of the transmission of virus. We've been having this, we've been hearing this story in few months ago, but when the summer happened to come, we see in one of the cities of Iran, which is called Ahwaz, it's near the border of Iran and Iraq. It's near the border. The temperature nowadays is above 45 centigrade, above 45 every day. And we've seen that unfortunately there is a high number of cases every day, and that state has been considered as red. So we have red. I don't want to complicate. your mind about that. But it's a high number of people of that particular city with that high temperature. So unfortunately, this virus seems to have no effect on it seems to not be affected by the temperature. So, and we have the rapid growing number of cases, whether in cold or hot cities. So that's the truth, which is an unfortunate fact.
Okay, thanks a lot. Yes, as I said, the distribution and the virus is presented everyone here. But as I noticed that the fatality is decreased. I don't know if it's true or not.
Yeah, about the fatality rate, from what I've seen, I've been following the statistics, international statistics on the number of cases and deaths. There is no significant difference between the time of like few months ago, which was in like spring, and there is no difference within that time and nowadays, which is the summer. So there is no significant difference, unfortunately, and seems that the virus is immune to any temperature from like the weather temperature. Of course, the high temperature, maybe more than 100, seems to have effect on the virus, but the weather temperature seems to play no role in the transmission of virus or the fatality rate. Or if any other panelists have any other idea or something opposite to what I'm saying, but I think the last I checked, this is the fact. If Dr. Baluch or other panelists have any other idea, happy to hear it.
Hassanan, it's Dr. Shabi Zaidi. Can I recommend to invite Dr. Bukhari, because he has been a frontline worker in Pakistan fighting the COVID. And I think this is a very interesting hypothesis that whether this particular infection, COVID, is related to any change in the climate, weather, particularly hot weather. So let's see if Dr. Bukhari is there if you'd like to share. Thank you.
Dr. Bukhari?
Is he not there?
No, he's there. He's there.
Can you invite him? Because he was really in the frontline battle in Lahore when the COVID was really killing hundreds of people there, and I'm not sure.
Yeah.
Is he responding?
I could see his name, but he's still muted. I even asked him to unmute. Yeah.
Just if I have a time, I want to talk about another point. From the starting of that disease, live in Kurdistan, Iraq. In some cities in the city that I live now, people don't care about protection, about social distances, and don't care about anything, and they live a normal daily life, and the market is full. They do picnicking, they do party in some places, but there's a script. I don't know why the disease is not so fatal here, if it's compared to other regions, other countries. As I said here, the people don't care about the self-protection. I don't know what the script.
Can I comment on that?
Go ahead,
Dr. Shabi Zaidi here. Dr. Bukhari is not there, but I know from my personal contacts in Pakistan that really when it started, everybody was fearful that it's going to be hundreds of thousands of people who will die. And the government had no facilities, and there was problem ventilators and hospitals. And I worked in Pakistani hospitals for years, so I know how pathetic the situation was. But strange things happened over the last 6 to 8 months. When we saw initially, there was an outbreak of massive, large number of people coming to various hospitals in Karachi and Lahore, Islamabad. And I was told by my friends, the frontline workers, that people would come and they'd literally die outside the hospitals because there were no facilities. And then came Eid al-Fitr, when people got out of their houses, started hugging each other and what have you. And everybody was fearful that it's going to be a massive toll in terms of deaths. But what happened, we don't know. The latest I've heard, and I've heard from people who are working like Shahzad is in Lahore and people like Rosenfer in Karachi, my friends who were frontline workers, that somehow either it was herd immunity or it was, I would say, God's grace, that the fatalities have been much less than they were anticipated. Now, this is a point which really one has to ponder over and look at the possible cause. It could be a very important subject for future research, because pandemics are bound to come. Only yesterday, it was the news here and BBC and ITV and everywhere that the coronavirus might come back in winter months. So there is a point to consider for research. What could be the factors? People talk about herd immunity. They also talk about passive immunization because we've been exposed to tuberculosis and malaria and parasites and dengue fever and whatever. Is it the natural immunity which is counteracting against this particular virus, the COVID virus? I mean, worth considering. Thank you.
Okay, thanks, Prof. Shabi, sharing your experiences for Pakistan.
Can I talk for a moment?
Sure, go ahead.
As I told in my presentation, the best way for such a disease as coronavirus is preventing of being infected. And the best way for preventing of being infected is following the what to do's that I've mentioned before. I mean, having mask, washing hands, and keep the physical distances will help to break the chain. After being infected, the work is harder because it needs some drugs, it needs a bed in hospital, and based on the cost effectiveness of the disease, it's not cost effective to be infected and to be hospitalized. So all the epidemiologists agreed to work on preventing methods instead of curing methods. Also, we have different drugs in Iran and different methods of curing patients, but what studies showed that if we work on the prevention part, it's much more better and have the best outcome for everybody and each person of the society. Also, we have the report of Mrs. Naribi of the Hashemi Nejad Hospital of the numbers of deaths and hospitalized patients. It's quite interesting. I do recommend to listen shortly to her to report about the patients of COVID-19 in their center. Thank you.
Hi again. I wanted to tell you about the statistics from the entrances into our tents. The COVID tents was entrance to our tents, and from them was 31.4% death from all of our patients, and 5.6% deaths from CT scan positive patients, and about 16.6% of our patients was intubation, and all of the patients all of the people who entered to our tents, 92.1% were discharged outpatient, and from them 7.9% were admitted to our wards. Thank you very much.
Thanks for sharing the data. I would ask Dr. Atif Beg to share experience, or if you want to ask any question.
Thank you so much. So actually, just want to add, and because with our little experience, firstly working in Malaysia, secondly working as a POR, basically, which is more like a program recurrence for clinical trials for NIH. I found we are so many applications, and this very serious issue of the temperature versus COVID-19 has been one of the minors. So what we found, special aspect, one is the dispersion, which is, when somebody is going to when somebody is going to sneeze, for example, or going to throw out a severe viral load. So how it is dispersed and how long distance is going to be dispersed. Number one. Secondly, the transmission. When the people they pick up the dispersed particles, or it's a direct transmission. So these two phenomena, they are actually being affected by a low temperature. They increase actually with the low temperature and with the low humidity. So just want to add this part in.
Yes, Ratif, continue.
So, Hassan bhai, this is something very important. Like at a low temperature, in vitro, the transmission and dispersion is very high. But at a high temperature, in vitro, the dispersion plus basically the transmission is affected. Even actually, obviously, it looks like it should be opposite, but practically it's happening in a different way. So the low temperature in all the coronaviruses is actually is associated with more stable virus. Number one, low temperature. Number two, low humidity. So this is one of the very big aspect. But yes, in vivo, there is no study done till now. There are the studies which were done on the surfaces, all those kinds, but all are in vitro. In vivo, we don't know. Looking at the pathogenesis, nothing has been reported. Yes, in transmission and dispersion, there is an effect. Just want to add this small part in.
Okay, thanks, Dr. Atif, for sharing your experience. May I invite Dr. Elias to summarize or give us closing remarks?
Yes, thank you very much for all the audience. In this workshop, we started from the nature of the disease and about telling some characteristics of the virus, about the signs and symptoms, and also we talk about the preventing methods of the disease. We summarize some methods for literacy, social literacy of COVID-19 and the nature of stigmatizing of this disease and the ways not to stigmatize it. And finally, about the emotional and self-care of the healthcare providers and the managerial tricks for them. We have two plenary sessions about the sharing experiences of nurses who worked in the COVID-19 wards, and about the managers who manages the centers for caring of COVID-19 patients. That was all about the disease. At the end, I want to really thank you and appreciate all supporters and all that everybody from the different parts of the world, from the Malaysia, from the Canada, and from here, from faculty and the university that for this workshop have been done. But at the end, I have unfortunately bad news about the next workshop, number 2 of this workshop that would be held.
Dr. Elias, could you unmute? Because somehow there was echo. I have muted wrong person. Sorry.
Do you hear me?
Yeah, now it's much better. Continue.
Sorry. Anyway, the next workshop has been cancelled, and again it will be announced, and the coordination will be, organized. This is the first workshop about the approach of nursing. I'm really happy and grateful of having such a wonderful colleagues besides me, and really appreciate Dr. Balchi, Shifa's, and Dr. Zaidi's efforts. And I want to say goodbye and see you next time in the next workshops. Thank you very much.
Thanks for all attendees and participants. I think it's almost the time to close this session. Before I close, just need to copy one of the statement or one of the message by Dr. Salehi about COVID. This is not a sprint marathon. So again, congratulations to all frontliners who are actually dealing it nicely and fighting, and all the best. And thank you for sharing all this information. And see you for next session. And sorry for all small glitches, Okay.
Thank you very much.
May we say bye too?
Okay, see you. Bye.
Yeah, okay. Goodbye, everybody. I think
Okay.
chance to. Yeah.
Bye.
Bye. Okay.